Happy Friday, Baylor College of Medicine. I'm not sure what week we're on. They're all beginning to run together. It's either week 20 or week 21, but we had a kind of a mixed week this week. As I told you last week, things were looking actually pretty good, and numbers were getting better. Let's start off with the national numbers. We have now become the worst country in the world with regards to COVID cases. We represent less than 5% of the world's population and 25% of the number of cases. Brazil is trying to get close to us, but I think we will continue to maintain the lead until we get a national policy. Couple of things. As I mentioned last week, I've been trying to get everyone focused on a different set of numbers, so I'm not going to focus on those other numbers that we talked about before. We are now officially over 100,000 cases in the Houston region. And one good thing is, even though we've got a lot of cases, our rate of increase is still only 1.2 times every 7 days. So if you'll recall early on in our experience with this virus, we were 2.5 to 3 times increase every 7 days. And now we're down pretty consistently in that 1.2 level. Again, last week I was talking about how we seemed to be over the hump and we were coming down. We even got down to 1,700 cases. Well, unfortunately, the last several days have been back up, closer to 2,000. And so we seem to be stuck at this level. It's not 100% clear why. I think I have some understanding of why, but it is interesting because we don't seem to be able to move the needle that much. The point that I made last week is that we shouldn't be following hospitalizations because that's not really the key number we need to follow. And hospitalizations continue to fall, as does ICU capacity. So we have plenty of capacity, and that's unclear why this continues to go. But the good news is we are about to start reporting on the 3 factors that I actually do think are really important. And this will be coming shortly to a theater near you, because all the theaters are closed. This is all you'll get a chance to see. But we are now actually reporting on the effective reproduction rate, which I told you before is an index of how much infection is happening in the community. We want that to be less than 1. 1 means we're winning. Over 1 means the virus is winning. Well, we're about 1.14 today, which is okay, but not great. It's not going to be good enough for us to do the things we want to do as long as it stays over 1. As I mentioned before, our daily new cases are really close, almost close to 2,000 a day. And until we're down to 200 a day, we can't even begin to think of like opening businesses and opening schools. We just have too many cases in the community right now, and it's really unclear exactly why that's happening. And our test positivity rate continues to fall a little bit. We're down under 15% for the first time in a while. But as I mentioned last week, we need that to be a lot closer to 5%. So where are all the new cases coming from? I asked Eric Borwinkle, who's the co-director of the Genome Center here at Baylor and the dean of the School of Public Health at UT, and he's been tracking both age and ethnic contributions to the pandemic. And right now, the vast majority of our new cases are under the age of 20. And that's usually, that's really between 15 and 20. And by far the biggest increase in race is in Latinx. And so we have a real problem in the young Latinx community that just needs to be addressed. And it's not 100% clear to me why that's happening. You would think if it was household infection that all age groups would be going up. But the mere fact that it's just in that one demographic makes me think we have a problem with groups getting together, large clusters. I think it's not just family transmission or household transmission with those kinds of numbers. So let's start thinking again about how this virus works. We've talked a lot about the virus dynamics, but we haven't spent a lot of time talking about viral transmission. And we do this experimentally in the lab a lot of time. We'll come up with what we call the infectious dose 50, ID 50, which is what number of viral particles do I have to give to an animal to infect 50% of the animals in the experiment. That's done under very controlled conditions. We don't really have that kind of understanding in man, but we can very easily quantitate in animal models exactly what that level is. But in man, when you think about it, if I'm infected as an index case, my ability to affect people is very much dependent upon how much virus I'm producing. And people produce different levels of viruses. People have different set points. Some are big producers of a lot of virus. Others produce very little virus. And then it's how do I spread that virus? The way we spread it normally is coughing and sneezing. That projects it out, droplets out 3 to 6 feet. But speaking also does it. And the other things that really project virus are singing and yelling. So we've had choir outbreaks and we've had prison outbreaks. And it's not surprising that that happens. Right now, most people in the field believe that fomites or on objects, doorknobs, surfaces, probably isn't that important. The vast majority of spread is probably through droplet spread, which is why masks are so effective and why we think social distancing of 6 to 8 feet really, really works. But the other and more interesting conversations recently have been, is this virus aerosolized? So aerosols are usually considered particles less than 5 micrometer in size. And classic, there's a good example of a sneeze. Luckily, I projected it that way, so it's 6 to 8 feet that way, not 6 to 8 feet that way. And coughing's also very good. So, but there is some evidence of aerosolization, and aerosols have been well known in measles. Measles has been the sort of classic respiratory virus that's transmitted through aerosols. A person who's infected could go in and cough or even just breathe, leave the room, and people can be infected hours to days later. Tuberculosis is like that. The spores sit up in the air for a long period of time, and so that's the reason that tuberculosis hospitals used to be highly ventilated, big windows bringing air through. That's the way you try and deal with aerosolization. So there have been examples of where we might think that aerosolization is important. It's still debated, but if you look at the large spreader events, those seem to be like opportunities where aerosols might happen. So one of the most talked about one is in Guangzhou, China. There was a restaurant and an asymptomatic person spread virus to 9 individuals that were not at their table, but the airflow from the air conditioner was blowing across those tables. The tables right next to that index case that were not in the airstream, they did not get infected. In Skagit, Washington, there was a choir practice where one single patient, or single index case, infected over half the choir. They were all singing in a small, poorly ventilated room, but that speaks to the issue of potential aerosolization. I mentioned before the Korean call center where 94 of 216 people on the call center were infected, and they were all within the same side of the building. And just think about a call center. They're on the phone talking all day long. So all day long, viruses are being spewed in there. And so you'd think that there's another example of aerosolization. But if aerosols are important, we've got to be thinking more than just masks. So masks, as I said, great for droplet spread, and we think the vast majority of spread happens through droplets. But if aerosols are important, then we should have different rules for indoors and outdoors. So most people, when they get indoors, feel pretty protected. You're with family, you take off your mask, you eat, you're close to each other, you're speaking. The problem is that is a perfect way to spread virus through aerosols. And remember, almost 50% of the cases in New York were from people in their own houses. So we're going to have to be thinking a lot more about how do we manage indoor spaces versus outdoor spaces. I've gotten a lot of questions from many people about what do I do when I'm outdoors? Can I be walking alone and take my mask off? Well, what I need to tell you is always keep your mask on, but the fact is if you're outdoors by yourself, there's no reason to have a mask on. And there have been very, very few outdoor transmissions. There has been an example of a couple of joggers who always jog together, very close proximity, where they have converted someone. But the vast majority of events outdoors do not lead to mass infections. It's group events indoors. It's choirs, it's churches, it's events, political rallies, political conventions. These are all things that are really a problem. And then you start thinking about schools, indoor schools, it's going to be, a real issue. So what do we have to do when we think about managing an aerosol problem within schools? We really need to focus on the physical plant, on ventilation, on air handling, on filtering the air, keeping windows open where available. We talked a little bit about HEPA filters and UVC light. UVC is used to when you collect air, run it by UVC, you can actually eliminate viruses in the air. So as we start talking about going back to schools, we're going to have to think not only about masks and distance, but how do we manage the air quality to make sure that if there is aerosolization, we're dealing with it. And that's got to be through looking at how we filter air, whether we are taking viruses out through UVC, making sure there's appropriate ventilation, and teaching a lot more outdoors. So one of the interesting things that's come up is, are all schools going to be the same? And a lot of concern about elementary school. Kids can't really manage the masks as well, and social distancing is very hard for kids in kindergarten through sixth grade. And you've heard several people, including our president, say, well, kids have a great immune system. Well, there's been actually some really interesting studies looking at the receptor that's responsible for the virus binding and getting into cells, the angiotensin-converting enzyme 2 receptor. And that receptor has been looked at in various age groups. And there's an interesting study that was just published in JAMA from a New York group that looked at what's the number of ACE2 receptors in the upper pharynx and nasopharynx of kids 0 to 10 years old, 10 to 20 and older. And it turns out that under the age of 10, there are very, very few ACE2 receptors in the nasopharynx. Almost 20%, 15% of what an adult has. That probably explains a lot why it's difficult or more difficult to infect really young kids and why they may not be as big a spreader. There are other things. I heard Dr. Fauci talking about T-cell immunity from other coronaviruses, and kids have lots of colds, so that it's possible that through a T-cell, a memory T-cell that recognizes coronaviruses, it might cross-react with the coronavirus that we have now, COVID-19. But one thing is clear, it's difficult for that virus to get into the cell if the receptor number is lower. If you look at adolescent kids, they have about half the number of receptors as adults, but by the time they're 20, it's the same. And so I could easily see that we have slightly different practices for kids K through 6 that we do for middle school and high school kids. College kids, unfortunately, even though they don't behave like adults, they have the same number of adult ACE2 receptors. So I think as we begin to plan to get back to school, all these factors are really important. We are nowhere near in a position to open schools. I don't know what the politics how they'll play out, but when we have almost 1,700, 1,800 cases a day in our community, that is just way too many to think about actually face-to-face school. But when we do open up, when we do go back to school, we've got to start thinking about things not just about physical distancing and masks, but ventilation, air handling. Are we filtering air? Are we treating air with UVC? And we probably need to do things a little bit differently for kids that are under the age of 10. So anyway, lots of interesting information. We learn more and more about the virus every week. In general, I think we're in Texas and Houston in particular, I think we're doing better. We do have this very specific increase in the young Latinx community that we have got to figure out. I don't know the behavioral determinants. I wish I did, but I think one of the things we now know is we have to look at that age group and that demographic much more clearly. So It's been an interesting week, lots of new information, lots of fun to watch what's going on TV. I've loved the fights between Brett Giroir on testing and Tony Fauci seemingly, being himself and relatively normal, and the rest of the administration. But it would be nice to have a national plan. I think it's going to be really important at some point. But I think we can do what we need to do here in Houston without one. We have the wherewithal to do what we need to do without worrying about the rest of the country, unfortunately. But I think we should really focus on what's best for Houston at this point. Anyway, have a great weekend. Baylor College of Medicine doing great as always. We finished the year much better than we could have ever expected. Our fiscal year ends July 1, and it was a relatively good year considering all the challenges that we've had. And it's a good year only because everybody at Baylor chips in. The clinical program came back to 90 to 95% of its strength. The basic researchers have been doing great at getting grants and doing research. Our teaching continues to go on, and our community activities have never been stronger. I appreciate everybody who works here, the staff, the folks at the front door, Billy who does the filming. It's really, really important that we all pitch in. So have a great weekend, Baylor College of Medicine, and I'll see you next week.